The human brain, the spinal cord, arguably the most complex structures we know. But what if you could really get inside their hidden maps, their vital pathways, not just to understand them, but to truly master them, what the top professionals do? That's exactly our mission today. We're doing a deep dive into some key source material, specifically from SNELLS Neuroanatomy, and we're really focusing on the clinical significance, the practical techniques that define expert practice. The goal here for you is complete mastery, moving way beyond just memorizing facts to a really deep, practical understanding.
Exactly. This isn't about just collecting bits of information. It's about getting the what, the where, and maybe most importantly, the why it matters in a real clinical situation. We're going to connect specific anatomical points, landmark structures, directly to how they're used in diagnosis, in surgery, and patient care, really bridging that gap, between the textbook page and the actual operating room.
Okay, let's jump right in then. We'll start with mapping the outside, the skull's surface. These external landmarks are just fundamental for neurosurgeons, for clinicians. Our source material starts by laying out what it calls the baseline of the skull. So imagine a line starting at the lower edge of your eye socket, the lower margin of the corbate, and extending backward. It passes through the top edge of your ear canal opening, the external auditory meatus. Now, this simple line, it's incredibly informative. The cerebrum, the main part of the brain, sits entirely above it.
Right.
And the cerebellum, back and bottom, is in the posterior cranial fossa, specifically below the back third of that line. It's like a basic navigational grid right there on the head.
And that kind of precision, that spatial understanding, is absolutely paramount in neurosurgery. You really need it. Think about structures like the falx cerebri, or the superior sagittal sinus, the longitudinal cerebral fissure. The falx cerebri, that's the big fold of dura mater separating the two brain hemispheres. The superior sagittal sinus is a large vein running right within it, draining blood. And the longitudinal fissure is that deep groove between the hemispheres. You can actually mark their position externally. Just draw a line over the very top of the head, the vertex, connect the root of the nose to that bump at the back, the external occipital protuberance. That simple external line gives you a vital reference for these critical internal structures.
Okay, so we have these foundational lines. Let's zoom in a bit. What about specific external signposts a clinician might actually feel for? What's the next key landmark and what's it pointing to inside?
That would probably be the parietal eminence. If you feel the side of your head, maybe 2 inches, 5 centimeters or so above your ear, you'll feel a slightly raised area on the parietal bone. That's it. Now, what's really insightful, clinically speaking, is that this bump, you can feel it lies very close to the lower end of the central cerebral sulcus of the brain.
The main divide.
Exactly, the major groove separating the motor and sensory areas. So this external bump is a surprisingly good pointer to the brain's sort of central operating system, a fundamental shortcut for assessment, even bedside.
That's a perfect example how the outside informs the inside. And speaking of small details with potentially huge implications, let's talk about the pterion. This one sounds particularly interesting.
Oh, it absolutely is. This is where a tiny anatomical detail has massive clinical weight, the pterion. So picture the side of your head near the temple, just above the cheekbone. It's not really a bump or a dip. It's a critical junction point, often quite fragile, where 4 skull bones meet. The temporal, frontal, parietal, and the greater wing of the sphenoid bone. Specifically, it's where that greater wing of the sphenoid joins the anteroinferior angle of the parietal bone. Location-wise, it's about, say, 1.5 inches, maybe 4 centimeters above the midpoint of your cheekbone arch, the zygomatic arch.
And why is that specific spot so critical, even if it's subtle?
Because of what lies directly underneath it. The anterior branches of the meningeal artery and vein. This is the vessel commonly involved in life-threatening epidural haematomas. So, knowing this precise anatomical link is crucial. You can potentially pinpoint the source of internal bleeding just based on this external landmark.
Right, that connection is vital. Okay, with those surface maps established, let's shift to a really critical clinical application, treating intracranial hematomas. When does the situation call for cranial decompression?
Well, the source material indicates it's typically when a patient shows progressive neurological deterioration. Their brain function is worsening. And crucially, signs of brain herniation are appearing. That's brain tissue getting squeezed out of place by pressure.
Right, a very dangerous sign.
Extremely. Especially these signs continue despite good medical treatment. And of course, ideally, you always want CT scan confirmation of the hematoma before you intervene surgically, if possible.
So once that decision's made, let's break down the temporal burr hole procedure. It's a common way to deal with blood collecting inside the skull. How does it actually start with the patient?
Okay, first the patient's positioned supine on their back. Their head is rotated so the side needing the burr hole is facing up. For instance, if a patient has a fixed, dilated pupil on the right, that often points to the unfissed part of the temporal lobe, herniating and pressing on the right oculomotor nerve.
Which controls the eye.
Exactly. So that strongly suggests a hematoma on the right, and the burr hole goes on the right. Once positioned, the temporal skin is shaved, prepped, then the incision. What's that first cut like, and what layers are involved right away? It begins with a vertical skin incision, about 3 centimeters long, and its placement is precise. About 2 finger breadths forward from the tragus, that little cartilage flap in front of your ear canal, and then 3 finger breadths above that level. Once you make the cut, you go through layers. First skin, then the superficial fascia that contains small branches of the superficial temporal artery. You have to manage those. Next is the deep fascia covering the temporalis muscle. Then the temporalis muscle itself, that big chewing muscle, is incised vertically, right down to the periosteum, covering the squamous part of the temporal bone.
The flat part of the temple.
Correct. That muscle is then carefully lifted off the bone, retracted. You usually get some bleeding from the muscle itself.
Precision right from the start, peeling back those layers. So once you're down to the bone, what's the next step? Drilling.
Yes. A small hole is drilled through both the outer and inner tables of the skull, going straight in, perpendicular to the surface. This hole is then usually enlarged with a burr. Unless, as the source notes, you find a blood clot already sitting there between the inner table and the endosteal layer of the dura.
The brain's outer lining.
Exactly, the tough outer membrane lining the skull. At this point, you should see the white meningeal layer of dura. It's flexible, gives a little under gentle pressure. The initial hole might be enlarged further with a curette. Any bleeding from the diplo, that spongy bone layer between the skull tables, is controlled, usually with bone wax. And then finally, the wound is closed carefully, layer by layer. Temporalis muscle, deep fascia, and the scalp itself.
That's incredibly meticulous step by step. It sounds like once that hole is made, what you see right then is absolutely critical. How do those visual cues tell you the source of the bleeding?
You've hit the nail on the head. That moment is a key diagnostic point. If it's an epidural hematoma, right after you get through the inner table of the skull, you typically find dark red, clotted blood sitting right under the endosteal layer of dura. Now, contrast that if you see bright red liquid blood. That points straight to active bleeding from the middle meningeal artery, or one of its branches, the vessel right under the pterion we talked about.
Ah, okay.
It's fascinating how these visual cues differentiate the source so clearly. And that artery, it can be deep to the clot, or between the dura layers, sometimes even inside the dura, or in a little bony tunnel.
And how does that compare to what you'd see with a subdural hematoma burr hole?
Right. Different picture. In a subdural situation, when you penetrate the temporal bone, you expose the endosteal dura. But here, you don't find a clot between the endosteal and meningeal layers. Instead, the fused layers of dura themselves appear dark bluish. The surgeon then carefully incises both those dural layers to get into the space between the meningeal dura and the arachnoid mater, that thin, web-like layer covering the brain.
Oh.
The classic sign of a subdural hematoma is the blood gushing out from this space. It leaves the brain, covered only by the arachnoid and the pia mater, the innermost layer visible deep in the hole. These visual distinctions are absolutely vital for guiding the next steps in treatment.
Okay, moving to another crucial technique, ventriculostomy. What's this procedure used for? What's the clinical indication?
Ventriculostomy is mainly for treating acute hydrocephalus. That's a serious condition where the cerebrospinal fluid, the CSF,
The fluid cushioning the brain and spine.
exactly, its flow gets suddenly blocked. This causes a dangerous pressure buildup inside the brain's ventricles, those fluid-filled spaces. It can be life-threatening. So a ventriculostomy is done to relieve that pressure by draining off the excess CSF.
And how is it done? Where does the needle go?
Well, the anatomical precision here is absolutely key. The procedure involves putting a needle into one of the lateral ventricles deep inside the brain. This is done through a burr hole, either in the frontal bone or the parietal bone. The landmarks for aiming the needle are very specific. If you use a frontal approach, the needle goes through the frontal burr hole and is directed downward and forward, aiming toward the inner corner of the eye on the same side, the ipsilateral inner canthus. If it's a parietal approach, the needle goes through a parietal burr hole, again directed downward and forward, but this time aiming towards the pupil of the eye on the same side.
And the depth. How far in does the needle go?
For ventricles of normal size, it's typically about 2 inches, maybe 5.5 centimeters, from the skull opening. And this is important in cases of chronic hydrocephalus, where the ventricles are already significantly enlarged or dilated due to long-term fluid buildup.
Right.
The depth needed to actually reach the ventricle might be much less.
So this need for adaptive depth, combined with those very precise aiming points, what does that really mean for the clinician in the moment?
It means having the ability to quickly, accurately relieve potentially fatal pressure. You have to tailor the technique based on the patient's specific condition. A dilated ventricle is a relatively large target, but hitting a normal-sized one requires pinpoint accuracy. That immediate adjustment, guided by understanding the anatomy and the pathology, that's what makes a difference in an emergency.
Okay, let's shift our focus now, moving down from the brain to the spine. We need to talk about the crucial link between vertebral number and spinal cord segments. This mapping is fundamental for figuring out where neurological problems are located. And our source material is very clear. It's not a simple one-to-one match all the way down the spine, is it?
No, it isn't. And that difference between vertebrae number and cord segment number is a common point of confusion, but getting it right is essential for diagnosis. For example, up in the cervical spine, you generally add 1 to the vertebral number to get the corresponding cord segment. So the C5 vertebral lines up with the C6 cord segment. Move down to the upper thoracic vertebrae, you add 2. For the lower thoracic region, T7 through T9 specifically, you add 3, then it changes again. The 10th thoracic vertebra relates to the L1 and L2 cord segments. The 11th thoracic lines up with L3 and L4. The 12th thoracic corresponds to L5. And finally, the first lumbar vertebra relates to all the sacral and coccygeal segments way down at the bottom. Understanding this complex map is the absolute foundation for interpreting neurological deficits related to the spine.
And the real practical value of this mapping comes alive when we look at segmental innervation of muscles, using simple muscle reflexes. These aren't just, quick checks. They directly test the health of specific spinal cord segments. What are some of the key reflexes clinicians use?
Oh, these reflexes are incredibly powerful diagnostic tools. They give immediate feedback on neurological function. For instance, the biceps tendon reflex, tapping the tendon, causes the elbow to flex that tests the C5 and C6 segments. The triceps reflex, tapping its tendon, makes the elbow extend. That checks C7 and C8. The brachioradialis reflex causes supination, a sort of turning up of the forearm that assesses C5 through C7. We also look at superficial abdominal reflexes. Stroking the skin makes the underlying muscles contract. Upper abdomen relates to T6, T7, middle T8, T9, lower T10, T12. Then down in the legs, the patellar tendon reflex, the classic knee jerk, that tests L2, L3, and L4, causing the knee to extend. And the Achilles tendon reflex, the ankle jerk, evaluates S1 and S2, making the foot point downwards, plantar flexion.
Right. Building on that, we need to tackle the relationship between intervertebral disc herniations, slip discs, and the spinal nerve roots, because a herniated disc can cause major problems. And the source immediately flags that key point again. 8 cervical nerves, but only 7 cervical vertebrae. How does that affect how we think about nerve root compression?
Yeah, that difference really matters clinically. In the cervical spine, for example, a disc herniation is usually named for the lower of the 2 vertebrae between, and it typically affects the nerve root that exits at that same level. But down in the lumbar region, it's often different. Take the L4 nerve roots. They exit laterally, close to the pedicles of the L4 vertebra. This means they're usually not affected by a disc herniation between L4 and L5. That L4-L5 herniation typically compresses the next nerve root down, which is L5.
Ah, okay, that's a crucial distinction.
It is. And our sources provide detailed tables correlating specific nerve roots with patterns of symptoms. Things like the pain dermatome, the specific skin area supplied by that nerve plus associated muscle weakness, and any changes in reflexes, like being diminished or absent.
Can you give us a couple of concrete examples of how that pattern looks?
Sure. Let's say a patient has a C6 nerve root problem. You'd typically expect to find pain radiating down the lateral or thumb side of the forearm. You'd look for weakness in wrist extension, affecting muscles like the extensor carpi radialis longus and brevis, and you'd likely find a diminished brachyradialis reflex.
Okay.
Or take an S1 nerve root issue lower down. The pain pattern is often along the lateral edge of the foot. The weakness would be in plantar flexion difficulty pushing the foot down, like standing on tiptoe involving the gastrocnemius and soleus muscles. And you'd expect a diminished ankle jerk, the Achilles reflex. This level of detail allows clinicians to really narrow down the location of the problem just by careful observation of these sensory, motor, and reflex changes. It really begs the question, though, how precisely can we localize these issues just based on these clinical signs?
A very important question indeed, because overlap can happen. But let's for now unpack one final crucial technique in this deep dive, the lumbar puncture or spinal tap. Absolutely fundamental in neurology. What's its main purpose?
Its core purpose is straightforward, to get access to the cerebrospinal fluid, the CSF. This is usually done for diagnostic tests, analyzing the fluid, or sometimes therapeutically, maybe to inject medication or relieve pressure. To do it, the patient positioning is key. Usually they lie on their side, the lateral recumbent position, or sometimes sitting upright. Critically, though, the trunk needs to be bent well forward, flexed. Why? Because this opens up the spaces between the adjoining laminae, those bony arches on the back of the vertebrae in the lumbar region. Maximizing that space is crucial for safely inserting the needle.
And finding the exact spot relies on clear surface landmarks. If you feel down the middle of your back, there's that groove over the bony spines of the vertebrae. It gets more obvious when you bend forward. But the absolute key landmark, you find the highest points of the iliac crests, the top curves of the hip bones. Imagine drawing a line straight across the back connecting those 2 points. That line typically passes right over the 4th lumbar spine. That's your target area.
Exactly. Once you've pinpointed that L4 spine, using strict sterile technique, of course, and local anesthetic to numb the skin and deeper tissues, a special spinal tap needle is inserted. It has a stylet inside, a solid wire, to prevent skin or tissue plugging the needle as it goes in. The insertion point is usually in the space either just above or just below that 4th lumbar spine. And the path that needle takes is through a very specific sequence of tissues.
Yes, and knowing that sequence, the exact order of structures pierced, is vital for any clinician performing this. It's like threading a needle through multiple layers of fabric. First, naturally, it goes through the skin, then the superficial fascia, which is mostly fat. After that, it encounters 3 ligaments, one after the other. The tough supraspinous ligament running along the tips of the spines, then the interspinous ligament between the spines, and then the really dense yellowish ligamentum flavum.
Strongest one.
Right. Once through the ligamentum flavum, the needle enters the epidural space. This space contains some loose fatty tissue and, importantly, a network of veins, the internal vertebral venous plexus, which you need to avoid. And then finally, it pierces the 2 membranes surrounding the spinal cord itself. First, the tough outer dura mater, and then the thin, delicate arachnoid mater. Only then does the needle tip enter the target, the subarachnoid space, where the CSF circulates.
And the depth you need to go can vary quite a bit. In kids, it might only be an inch or less. In heavier adults, it could be as much as 4 inches, maybe 10 centimeters. Once you're in the right spot, in the subarachnoid space, you can measure the CSF pressure. Normally, with the patient lying on their side, it's around 60 to 150 millimeters of water. That pressure reading itself is another key diagnostic clue.
Wow, what an incredible journey we've taken today, really getting into the weeds of clinical neuroanatomy. From mapping those crucial skull landmarks that guide interventions to the detailed steps of procedures like burr holes and ventriculostomies, and then understanding the diagnostic power hidden in reflexes and CSF analysis. This deep dive, pulling from SNELLS, has really aimed for that professional level of mastery, trying to equip you with practical, high-level insights.
Absolutely. And if we sort of step back and connect this foundational knowledge to the bigger picture, well, it's clear these anatomical principles are timeless, right? But our ability to interact with them is constantly changing. It makes you wonder, how might new technologies, things like advanced imaging, maybe robotic-assisted surgery, even AI helping with diagnoses, how they continue to refine our understanding, our manipulation of these incredibly delicate structures? How will they push the boundaries of what we can do in neurology, building directly on the kind of mastery of fundamentals we've explored today? It really highlights that constant interplay between knowing the foundational anatomy and embracing innovative clinical practice. Something to think about.